I have Dr. David Bates with us today. Dr. Bates received his undergraduate degree from Stanford and his medical degree from Hopkins, did a residency in internal medicine at Oregon, and a fellowship here in Boston in research fellowship in medicine, and also a master's at the Harvard School of Public Health. He's the chief of the Division of General Internal Medicine and the medical director for clinical informatics with the Partners IT system. And he's really been at the vanguard of helping transition us from a paper-based health system to an electronic-based health system. And he's been here right from the beginning of that effort, has published many, many articles on how this transition from paper to electronic impacts medicine. So it's wonderful to have you, David.
Well, thanks very much, Bob, and it's great to be here. So I'm going to talk this morning about patient safety in obstetrics and gynecology. And I want to start by disclosing the following financial relationships. I'm on advisory boards for Zinx and Intelidot. I'm not going to talk anymore about either of those companies beyond this. So I elected this morning to focus a bit on the interface between IT and safety because that's such an exciting area right now. And that's will be the main focus this morning. I'll talk a little bit about broadly what we know about safety. Then I'll say a bit about medication safety in obstetrics. Then I'm going to talk about the impact and potential impact of information technology. I'll tell you about what the evidence of benefit is, both in the inpatient and the outpatient settings. I'll tell you a little bit about some problems that can be created by information technology because things don't necessarily get better when you start using it. Then I'll tell you a bit about what's going on regionally and nationally because this is an exceptionally exciting time, probably the most exciting time ever in the area of information technology, and then I'll wrap up. So Paul O'Neill was the former CEO of Alcoa, and he said that safety is not a top priority, safety is a precondition. And yet I would submit that that's not the way that we've looked at things in healthcare. If it were, we wouldn't allow situations like that. Does this look safe to you? I think if you look at that, it's obvious that a nurse could become confused about what's up at the top and what's going in down below, and that does indeed sometimes happen. Anybody want to tell me what this says? Right. So strong votes for Coumadin 4 milligrams. This is actually a prescription for Evandia, which is an oral hypoglycemic. And handwriting is not our only problem. It actually causes only a small proportion of the medication errors, but it's something that we know how to deal with and that we ought to get rid of today. Now, this whole problem kind of came into the public's eye with the publication of the 2 Errors Human Report, back in 1999. By the Institute of Medicine. And that report made 4 main points. It suggested that errors were common, that they're costly, that systems cause errors, and that errors can be prevented and systems and safety can be improved if we change the systems of care that we use. We now have more and more information from all over the world about how big a problem safety is, and it turns out it's a big problem everywhere. The first large epidemiologic study that was done in this area was done in New York. It was the Harvard Medical Practice Study. And in that study, 3.7% of the hospitalizations in New York State resulted in an adverse event. 58% of those were judged to be preventable. People said, well, that's New York. New York is hardly representative of the rest of the country. The study was repeated then in Colorado and Utah, which are 2 very different states, and they got essentially the same findings. Then a large epidemiologic study was carried out in Australia. The rate there was actually 16.6%. And when you looked at it carefully, it turned out that what the Australians had done was to very strictly interpret the definitions that were being used, and they were counting, for example, every hospital-acquired urinary tract infection, which had not been done as rigorously as it might have in the medical practice study. Another study from the UK arrived at a figure of 10.8%. There are now similar results from Canada, New Zealand, many other countries. And to summarize, the rate in most countries appears to be about 10%. We have less data from developing and transitional countries. I'm actually involved with the World Health Organization and leading an effort for them to leading the research arm of something called the World Alliance for Patient Safety, and we've just sponsored primary data collection studies in those countries. And actually, in developing and transitional countries, because many of them have such high birth rates, obstetric and gynecological issues end up being very high on the list of harm. Now here's some data about medication safety in the OB setting. Some data that was submitted to a spontaneous reporting. The U.S. Pharmacopoeia MedMarx program identified 3,800 medication errors from all obstetrical areas. The clinical areas where errors were reported, about roughly half came from L&D, 10% from OB recovery, and then 41% from the maternity units. And there's a list of the drugs most often involved. It's a lot of drugs that you, I'm sure, use a lot of. The most frequently reported causes of errors were performance deficits, which are identified at over 40% of the time in the reported cases. And some of the other identified causes and contributing factors included procedures and protocols not being followed, communication, documentation, knowledge deficits, and inaccurate or omitted transcriptions, and then staffing inadequacies and overly high workloads. So here's a case example. In June 2006, an 18-year-old gravida died after receiving an overdose of magnesium sulfate for preterm labor. And what happened was she was given a 16-gram bolus of magnesium sulfate instead of the prescribed 4-gram bolus. The investigation showed that the patient was given an intravenous solution that contained 40 grams rather than an IV piggyback solution of 4 grams. And the cause of the error was attributed to a mistake in a calculation that the nurse made. Now, you might think that this is an isolated occurrence. In fact, if you look more broadly, there are 52 reported prior cases of magnesium sulfate accidents that have been reported before this death in Florida. And a lot of them had really severe consequences. 7 of the errors resulted in maternal deaths or persistent vegetative state. I've always thought of magnesium as being a relatively innocuous drug, but if you give a big enough overdose of it, it really is not. And some of the causative factors associated with lethal overdoses of magnesium include using too much magnesium in a bag, temporarily removing the IV infusion from the infusion pump, having a really busy unit, and transfer to a less intensive level of care when somebody was receiving this medication. And magnesium has actually made it to the Institute of Safe Medication Practices list of high alert medications. Okay, so now I'm going to transition over a little bit to healthcare information technology. And here's some data from everybody is trying to figure out, our healthcare costs too much, what can we do to make it cost less? This is one list of national ideas for improving efficiency. HIT ends up coming up towards the top in almost all of these. But other things that end up being fairly high on the list include things like a Center for Medical Effectiveness, which could potentially save $368 billion. I'm not going to go through the full list, but one point I want to make is that health information technology could help us realize some of the savings from many of the things on this list. And if we want to improve the efficiency of care, I think we do need to start using more HIT broadly, nationally, in the care that we deliver. Now, the stimulus package provides a very substantial infusion of cash for implementation of health information technology. And it will offer $19 billion in the near term towards this. The way that this is mostly going to be delivered is in individual dollops to providers who implement HIT. So if providers have implemented, they'll get $44,000 per provider in the outpatient setting. In the inpatient setting, it's kind of complicated, but it will be millions of dollars per hospital. The Brigham, for example, will get roughly $5 million more per year as a result of payment from this. So it's a substantial amount. One thing that people will need to be able to do to actually get this money is that you have to demonstrate what's called meaningful use. And meaningful use is a term that's included in the legislation, but what everybody is arguing about today is what that actually means. and it will be defined by Health and Human Services through rulemaking. The legislation does say that it will include electronic prescribing. It will include participating in clinical data exchange. That's kind of tricky because if you're a small practice, and there's nobody to communicate with, how do you participate? It's easy for us. And it will almost certainly include something about decision support. David Blumenthal from Mass General is the new national coordinator for healthcare IT, and he'll have a very big role in deciding what meaningful use actually is. Now I want to just take you through a framework for how information technology can improve safety. And I think that there are three primary ways. The first is by preventing errors and adverse events. That's probably what most of us think about. But a second way is by facilitating more rapid response after an adverse event has occurred. And third is by helping us track and provide feedback about adverse events. And the old way that we found adverse events was to just wait for somebody to spontaneously report them, and that systematically underestimates their frequency. This is a framework for thinking about the main strategies for preventing errors and adverse events using information technology. First here on the list is tools to improve communication. And delivering good medical care is inherently very communication intensive. If you want to do well, everyone needs to be on the same page. So the nurse ought to know what the plan is for the patient, and the pharmacist ought to be able to figure out what the doctor and the nurse are thinking. And yet, I think we all know what it's like in today's practice. It's often hard for everybody to get on the same page. IT ought to be able to help us with that. Second, it ought to be able to help by making knowledge more readily accessible. So if you need information about a drug, you ought to be able to click on a button and go straight to that information. It can help by requiring key pieces of information. It can help by assisting with calculations. Go back to the magnesium example. It can perform checks in real time. It can help with monitoring, because monitoring is inherently a very boring sort of thing to do, and computers do it better than people. But when you have a signal, you really need a person to evaluate the importance of it, because the machine cannot do that. And finally, it can help by providing decision support. There are a number of IT applications that can be used to improve safety. First that I'm going to talk about is computerized physician order entry, which we've used here for a long time. Then I'll talk briefly about smart pumps, which are ubiquitous here, and you use them all the time. Then I'll talk about smart monitoring, computerized notification about critical test results, computerized monitoring for adverse drug events, and then finally tracking of abnormal test results. So actually, a lot of the data about the impact of CPOE comes from here at the Brigham. We did this work a long time ago. In one study that we did, we found that even with very simple computerized decision support, there was a 55% reduction in the serious medication error rate after we put in place computer order entry. And there's an 83% reduction in the overall medication error rate. It turns out that the serious medication errors are the errors that either hurt someone or have potential to do so, and it's a little harder to prevent those than it is to prevent some of the less serious ones. And CPOE is the single most powerful intervention for improving medication safety to date, but it has a lot of downsides too. It's not easy to implement it. You have to implement it well. You essentially have to use the vendor that you use for your main computer system to implement it. You have to have associated decision support if you want to see a high level of benefit, and you have to monitor it and then keep finding issues and making changes. And one of, I think, the responsibilities that we all have is just to provide feedback to the people who run the system so that we can continue to make it better. This slide shows how computerizing ordering improves safety, and it first of all, it streamlines and structures the process. So if you are picking doses from menus, you're less likely to make a serious error. You can decrease transcription. You can require complete orders. You can give information at the time that it's needed. So, for example, show relevant laboratories or display guidelines. And then finally, you can perform all these checks in the background. Now, I thought when I started this a long time ago that we would just get a list of the allergies and the drug-drug interactions and put those in, and in a year I would be doing something different. And it turns out that it's kind of complicated to set up these things, and In fact, if you just take the off-the-shelf products for drug-drug interactions, you end up seeing so many drug-drug interactions you just can't even really practice. It's just not useful. So we had to go through and use experts here to downgrade many of those, and we only show a small fraction of the total drug-drug interactions that are in most of the commercial databases. Similarly, for allergies, we've refined things a lot. It's still not perfect, and there's some improvements that still need to be made. One issue that comes up, for example, for allergies is if somebody is allergic to one narcotic, most of the time they get some nausea with one narcotic, and if you give them another narcotic, that's not that critical. That's something that we're planning to turn off. I don't think it's been turned off yet, but that's responsible for a very large proportion of the allergy warnings. Another study that we did subsequently was a study called the Nephro study, and this is a study looking at the effect of providing real-time decision support for patients with renal insufficiency. This is obviously especially important in gynecology. Of 18,000 patients admitted here at the Brigham, 42% had some degree of renal insufficiency, and in particular, older women, often even if they have what looks like a relatively normal appearing creatinine, will actually have decreased renal function. And we found that before we implemented decision support for this, people only got the right dose and frequency of drugs 54 and 35% of the time here at the Brigham. And then after we implemented the intervention, that went up to 67 and 59%, which was a substantial improvement. Notably, patients with renal insufficiency stayed in the hospital half a day less after we did this. So that was a fairly substantial difference. Another study that we did more recently looked at guided prescriptions for geriatric inpatients, and here the issue is that elderly patients frequently get dosages that are too high, especially initial dosages. We did a randomized controlled trial in which we looked at decision support for psychoactive drugs and found that after we put this in place, patients more often got the recommended dose, although they only got it 29% of the time versus 19% of the time. So not exactly fabulous performance there. But they were half as likely to fall, and they had a lower frequency of tenfold overdose. There was no difference for mental status change or length of stay. So clearly it was beneficial to suggest starting with a lower dosage, but also there's more room for improvement. Now, there was a case in Indiana not too long ago, which many of you may have heard about, happened in a neonatal intensive care unit. And basically what happened is that 3 babies died as the result of getting a heparin overdose. And what had happened was that the carts are loaded down in the pharmacy, and there are 2 strengths of heparin which look quite similar. The high strength of heparin was loaded by mistake in the cart, and then that was sent up to the NICU where the provider gave it. And it took a couple of cases, obviously, for them to catch up with this. This is the same thing that happened to Dennis Quaid's twins. So this is a error that has received a lot of attention. Turns out that dispensing errors are relatively common in hospital pharmacies, in part because of the very high volume of medications that are dispensed. We estimate that we have roughly 44,000 errors per year in this hospital, where we dispense 6 million doses per year. And many of these dispensing errors do have the potential to harm patients. We estimated more than 9,500 errors with potential for harm. Only a third of those were caught prior to administration. I always had the impression as a provider that the pharmacy had good strategies and they'd pick most of them up. In fact, that's not the case. Here at the Brigham, we recently implemented barcoding down in the pharmacy so that every medication is checked before it is dispensed. And doing that resulted in a 31% decrease in the dispensing error rate, a 63% reduction in the potential adverse drug event rate. This is work that was led by Eric Poon. It was published in the Annals last year. Here's some. So we did this really as a kind of an add-on. We were about to implement point-of-care barcoding, and we thought it might be interesting to see whether there was an issue in the pharmacy, and there was a much bigger issue than we'd expected. So Subsequently, we've done a study looking at administration errors at the point of care. And here's some data from that study. These data are not yet published, but I just thought I would share with you the early results. In this study, we looked at nearly 7,000 doses without barcode scanning, about 7,000 with barcode scanning, and you can see the distribution by medicine, surgery, and the ICU. This had a very substantial impact on decreasing the administration error rate. There was a 40% reduction in the medication administration error rate, and the potential adverse drug event rate fell by 51%. So quite substantial reductions. We haven't yet done the cost-benefit analysis for this part of things, but the cost-benefit analysis that we did, just looking at dispensing, showed that it was cost-beneficial to do this in addition to improving safety. And I think that I'm hopeful that this study will result in many other hospitals around the country finally making the move to barcoding. Some other work that we've done looked at the impact of safe IV systems. Here we evaluated the impact of smart pumps, which were developed by Cardinal Laris. And the reason that this work is important is that very few administration errors get caught. So there's nobody really between the nurse and the patient. If they make a mistake, it's going to get to the patient. And yet, IV errors can be especially dangerous. One case is a heparin bolus dose of 4,000 units, which was followed by an infusion of 890 units per hour. In this case, the bolus dose was given appropriately, but the nurse misinterpreted the order and programmed the infusion device to deliver 4,000 units per hour and not 890 units per hour. In this case, the smart pump alerted the nurse, and they caught the mistake. We performed a randomized controlled trial here. Actually, it was a controlled trial. It wasn't randomized. And what we found was interesting. So we found that serious IV errors were frequent, and that we could find them using the smart pumps. And we found lots of errors that we would have not found previously. However, there was no impact on either the serious medication error rate or the preventable adverse drug event rate, which was disappointing. And there were a couple reasons for this. One was that when we started with the smart pumps, it was very easy for the nurses to go around the software. In fact, that was the easiest thing for them to do. And surprise, surprise, that's what they did a lot of the time. And second, even when they did get a warning about an overly high dose, they often ignored those warnings. But one of the things about the smart pump is you can tell exactly what happened, what warning was shown, who the nurse was, and we were later able to go back through and kind of figure out exactly what happened. Broadly, though, I think this suggests that both behavioral and technological factors have to be addressed if smart pumps are going to achieve their potential. Subsequently, the manufacturers made a lot of changes in the pump, and now you are led through using it every time. And there's also a lot of work has been done by nursing to educate nurses about the importance of some of these warnings. Smart monitoring is also an interesting area, and you all do an awful lot of monitoring. That's a very big part of what you do. Computers can do this better than people, but as I mentioned, people are much better than computers at evaluating the importance of signals. I think this is going to have a huge impact in lots of places. Already is having an impact in ICUs, but I think it also will have an impact in general care units and home. And soon, I think we'll be able to take a lot of the monitoring signals that we today discard and retain those. That has its pluses and minuses because you don't necessarily want the lawyer to be able to go back and go through things. But I think we'll be able to look at combinations of things and perhaps detect earlier when a patient is not doing so well or the baby is not doing so well. Another study that we did looked at improving responses to critical laboratory tests. And here we looked at high and low sodiums, high and low potassiums, high and low glucoses, and falling hematocrits. And before we put any intervention in place, we found that about a third of these tests didn't get dealt with by anybody here at the Brigham for over 5 hours, which is a long time. After we put in place the warning system, the mean time to treatment fell 11%. And for events that didn't meet the lab's calling criteria, which were strict threshold criteria, they fell 21%. The mean time to resolution was 29% shorter. Tantalizingly, the mortality rate was 7% in the intervention group and 13% in the control group. Not statistically significant, but clinically meaningful. And furthermore, physicians were very happy to be paged about these things. Another study that was done a number of years ago looked at cross-coverage, and the before data showed that patients who were being cross-covered had 5 times as high a risk of an adverse event. After putting in place computerized sign-out, there was no excess risk, and that included things like medications. This was simple from the IT perspective, but it delivered a major benefit. Now, there's several areas outside the hospital in which information technology can help, and some of the big ones, I think, are prescribing, monitoring, and following up important abnormalities. I'll focus on the last one of these because that, I think, is especially relevant to this group. Dilbert had a comment on this, and the doctor here says, "It seems we had a mix-up with your test results." And Dilbert says, "Then I'm not dying." The doctor says, "We doctors are amazingly smart, but occasionally we make a little error." And Dilbert says, "Well, I understand." And the doctor says, "By the way, your pap smear was normal." Right? And I would submit that that's about where we are today in terms of dealing with these abnormal results. Not exactly perfect. So here's some data about this. About a quarter of diagnosis-related malpractice cases are attributable to failures in the follow-up system. Data from a large study in the Boston area found that 37% of women who had an abnormal mammogram didn't get their repeat mammogram within the suggested time frame. Many of those were the ones where there's a kind of a plus-minus abnormal, and you're asked to repeat one in 6 months. But still, we should be doing those. And nationally, about a third of patients with abnormal pap smears are lost to follow-up. Clearly, not so great. So to help deal with this, Eric Poon in our group developed this tool called the Results Manager, which basically takes all your results, it prioritizes them according to degree of abnormality. The most important ones are at the top here with 3 asterisks. Do you all use Results Manager? Some people do, anyway. Not everybody is shaking their head. But this is a really great tool. It actually won an award as best IT application developed, not just for healthcare, but nationally. And also with a single button click, it'll generate a letter which includes lots of text about what needs to be done in terms of follow-up, and then you can edit it a little bit and ship it off. And this has been very well received, and I think it's one tool for improving our management of these things. We also, though, need to make sure that we deal with 100% of the abnormal pap smears, and I know most practices have tools in place for that, but we need it really for all the markedly abnormal results. So we ought to make sure that we're following up 100% of our abnormal pap smears and 100% of our abnormal mammograms and so on. Now, another thing that is a really hot issue nationally is interoperability or clinical data exchange. And clinical data really can move from place to place in only a few sites in the United States. Notably, in Indianapolis, they've set things up so that information can move from one entity to another. Similarly, in Cincinnati, within the VA, they have really a good interoperability. The key approach in the United States has been to promote the development of something called Regional Health Information Organizations, or RIOs. This has a lot of potential benefit. Some data from the Center for IT Leadership here at Harvard suggests that standardized encoded electronic information exchange would save the U.S. healthcare system $337 billion over a 10-year implementation period, and then $78 billion per year for each year afterwards. It would also dramatically reduce the administrative burden associated with manual data exchange. In particular, it would help by decreasing unnecessary utilization of duplicative laboratory and radiology tests, although there are lots of reasons that this would be beneficial. We did a survey that was just published in Health Affairs. And we surveyed 145 RIOs around the country in 2007. Only 20 were actually large and exchanging data. Many of them were defunct. At least we couldn't find them using Google, or that is not a good sign for entities today. Most of the successes involved laboratory results, so there was much less information about other things that was moving around. And I think this study raises significant questions about the current business models. As it turns out, many of the benefits of doing this go to the insurers, and they are not providing very much money for most of these efforts. So that's a big problem. I think that clinical data exchange is probably a common good, and it's something that we will need to support societally if we want to see it actually take off. Personal health records are another area where there's enormous amount of interest. There's lots of action in this space. You probably read about Microsoft's Health Vault and Google's Google Health. Lots of organizations have also developed personal health records, including us. The best architecture is uncertain. I think that we'll get the most benefit from personal health records if they are linked to some health entity with some health information, namely, an organization like Partners. Because without that, it's just sort of hard to know how accurate the information is. The Partners has developed a number of initiatives which are called the High Performing Healthcare System Initiatives. How many people are familiar with those? Bob certainly is, but yeah, a few people are. But this is, I think, an exceptionally exciting sort of set of developments. There's 6 of these. The first one focuses on IT, and there are 2 things that we elected to do. One was to take inpatient computer order entry and roll it out to all the little hospitals in the network, because they were not necessarily going to get around to doing it if they did not have some help. And the second was to get all the providers and partners to use electronic records. We have roughly 7,000 providers and partners, and they're now almost all up on electronic records. So that's an exceptional accomplishment. The second of these, and the reason that this was first, is because essentially all the other ones depend in some way on having that information backbone in place. A second of these initiatives focuses on safety, and here there are several things that have been done. One is to try and standardize the medication-related decision support across the various sites. And this makes a lot of sense for a variety of reasons. One of which is, if you're allergic to medication over in Newton Wellesley and then you come over here, it's pretty likely that you'll still be allergic to it by the time you get here. And yet, our old way of dealing with that was not to move that sort of thing around. A second thing that we are trying to do is to implement proactive tools to look for adverse drug events and implement standardized web-based reporting so that we can make some comparisons among institutions according to what's reported. The third focuses on making more uniform decisions about administration. In the past, basically, what pump got picked was based on who was friends with whom, and sometimes there was more to it than that, but not necessarily. And the last area of focus is on standardizing information exchanged at transfers, which represent really vulnerable periods. I think the future potential of IT for improving safety is huge, that it's hard to estimate. I expect to see a very large improvement with medication errors, maybe on the order of 100 or even 1,000-fold. With surgical errors, I don't expect the improvements to be as big, but communication clearly is key. There have been some very big successes with tools like checklists, which Atul Gawande has implemented in surgery. For many types of errors in the outpatient setting, like monitoring errors, I think we could do much better. And I would suggest that the bottom line is that we're a long way from delivering the same sort of promise that Federal Express will deliver you today. I mean, if you take a package to Federal Express, they guarantee you that it'll be where you want it to be the next morning. And I don't feel like we can do that for a lot of the things that we do here in healthcare. There are a number of organizational factors which are associated with high levels of performance with respect to safety. And those include having a shared sense of purpose, having a hands-on leadership style, having accountability systems for safety and quality, focusing on the results, and building a culture of collaboration. Those are all things that we've tried to work on pretty hard here at the Brigham, but that's an iterative thing, and it really does take time. I think to actually get to really high levels with respect to quality, we're going to need a few things. And I think you have to be using an electronic health record because it organizes information and makes it easy to ask lots of questions. But we'll also need clinical decision support at the point of care. We will also need registry tools, so it's very easy, for example, to generate the list of all the patients who are pregnant in your cohort who you expect to deliver at a certain interval. And I don't know that we can do that today for OB. We now have pretty good lists like that in primary care, so we know all our diabetics and kind of where they are with respect to things. But the third thing that we'll need is I believe, is team care, so that we as the physicians begin to delegate some things to other members of the team, and we work together to make sure everybody gets what they need. I also think that we'll need to begin to actually measure our performance on lots of measures, and the right number is probably hundreds, which is a little scary, but that's probably where we're going in the near future. And there will also be a lot of transparency, so we'll take our performance on these measures and we'll make it available to people. We'll put it on the web, and you'll be able to look and see how do organizations stack up. On the safety front, I think that the key issue is making our essential processes more reliable. And here I would point to the remarkable success of checklists, for example, in reducing central line infections, work that was done by Peter Pronovost at Johns Hopkins. And a similarly major reduction in the rates of ventilator-associated pneumonia. But I think where we're going is that we're likely going to have dozens of checklists, and it's going to be a little tricky kind of managing all those. I also think we'll need new approaches like CPOE and barcoding, and we'll have to measure how we're doing in an ongoing way much more rigorously than we do now. In terms of getting where do we need to go with health information technology from the policy perspective, I think we need incentives for adopting HIT. We have that with ARRA. The main weakness of that is that there hasn't been maybe as much help for practices that need to adopt as would be ideal. There's just this money on the table, and it's not clear if you're not in an organization like Partners, who's going to come help you actually do it. There are a number of key standards that need to be moved forward. We need compendia of decision support. It turns out that with respect to decision support, everybody's pretty much doing their own thing, which is very wasteful. We need to sort out to what extent decision support should be standardized. Need more research on the next generation of HIT. There should be a lot more transparency. And finally, we're going to need to find an acceptable balance between privacy and interoperability needs. And there are clearly trade-offs when you get to moving clinical information around. So to wrap up, I think this is a very exciting time. I hope that we're near a tipping point with respect to implementing HIT and perhaps improving safety. I believe that IT can substantially improve safety today. We have a lot of data about medication safety, but it can have an impact in many other areas, some of which I talked about. Clearly, it can also create new problems. When it does that, you have to track those and engineer them out. Anytime you change a system, you find new issues. I think the future is going to include many new opportunities for improving care. And hopefully, if we all pull together around this, the net will be a safer system. And hopefully, at some point, we'll be there. It says it was done by a doctor. It's called orders. So I'll stop there and take questions.
It was a fascinating talk. There's so many places one could start. You had cited the difficulties with the smart pumps and how, because they were difficult to use, nurses tend to circumvent them. A lot of the IT systems that we deal with on a day-to-day basis in the inpatient world here have a sort of 1980s feel to them in terms of the interface. They tend to be very user hostile. Inputting allergies and allergens is one example. trying to change medications, when we're trying to, often if there's a change in therapy, it involves discontinuing several medications, which has to be done. The interface makes it very difficult to do that efficiently. What is being done here right now to upgrade and integrate and make more user-friendly the inpatient tools here?
Yeah. So, great question. The current interface does come from the 1980s. The advantages of it are that it's very fast, and that once you know how to use it, people end up feeling pretty comfortable with it. But it is clearly old. The current focus is on moving to acute care documentation, and that's the big change that that we will be seeing over the next year or two. The idea is to get us all documenting electronically, put all the vital signs up electronically, and the plan is not to work on the BICS interface until after that. So it's probably sort of 2 to 3 years off. I'm kind of impatient about that. I mean, I would like to see us move forward faster than that. But there will be very big benefits with acute care documentation. Just for example, when the surgeons go to the VA to round, they have to show up. They can show up 45 minutes later than they do here, because at the VA, all the information is electronic, and they can very rapidly get it, figure out who had a fever last night, all that kind of thing. So there will be very real benefits for everybody in the room here, I think, from acute care documentation. That being said, we also need to do what you talked about. There are a bunch of changes around allergies that have been on the list of things to do for a while, and they're just stuck in the queue. Yeah.
What's the problem with each medical center? They have their own proprietary medical record system. Wouldn't we have been better off just to start with the VA system? Free.
Yeah. Well, so the VA system is free. It turns out that on the inpatient side there are about 5 major vendors nationally, and I don't think I personally don't believe it would work to have one single system. Actually, all the countries that have been successful in this regard have at least several systems. You don't want to have a huge number, and in the outpatient side, there are 200 companies that make electronic records. That's way too many. So you have. I think that the ideal is to come up with some sort of happy medium. It is a big issue that everybody is doing their own thing. Yeah.
As far as the problems with the interface, it seems to me if you don't make that process easier, then the danger is that people will circumvent the system. And I think about the example of, say, thromboembolic measures. That there was data, I think, I remember St. Goldie was saying that that there was really only data that people, even though they were prompted and even though it was appropriate for them to take some thromboembolic measures, preventive measures, that they would just bypass the system.
Clearly, paying more attention to human factors is pivotal, and we actually have several people now who just work on the human factors part of things. With respect to all the new systems, I think we're doing a pretty good job with dealing with that, and the issue will be just going back and kind of redoing things for the inpatient system. So I agree with your point.
About people who refuse to give you personally identifiable information. I refuse to give you social security, or they say to you, I refuse to give an electronic medical record.
So the question is, what do we do with people who refuse to be in an electronic medical record? And it turns out that if you want to get your care at the Brigham, you have to be willing to have your data in the electronic medical record. Everyone who comes here for care has to sign something saying they agree to that. We made the call that we can't really care for people if they are not willing to have their information in the electronic record. Now, it's a different thing when you talk about moving their health information from place to place, because there, we have allowed people to opt out. And there's another effort I didn't talk about today called the Massachusetts eHealth Collaborative, in which we got $50 million from Blue Cross, and we're trying to get all the doctors in the state to use electronic health records. There we've set up clinical data exchanges, and we do allow people to opt out of having their information move around. Only about 1% of people opt out. But if you let people opt out, it just really diffuses things. So I think that's a useful thing to do. Yeah.
Could you address the human factors on the professional's part that leads to resistance to these changes? And could you offer one or two suggestions on how people can help other people to overcome their resistance?
Sure. So, provider resistance to doing some of these things has clearly, been a big issue, especially historically. Gradually, it's declining as people are more and more comfortable with using information technology. I think it's useful periodically to look and see how decision support is being used, for example, by the members of a department. And if you find that there are issues or someone's an outlier, it's just worth having a conversation with that person or persons, just in a very collegial way. Often there's something that somebody just didn't know about that can make things substantially easier. And there have been a number of instances in which there was something that I missed that I should have known about, and that was really creating problems for me in one specific situation. So that's something that I think we all have to work on over time. One thing I would encourage everybody to do is, if you see something that is wrong in the system, and there are things that are, just use the feedback button. And if you do deliver feedback, one of the nice things about having built our system ourselves is we can fix the problems, and IS does make that a very high priority.
There's been a fair bit of opposition to this whole system for security reasons. And it's been in the JMA and certainly the other journals. And hackers, have been able to get into the system and get people's medical information. And as far as I know, this has not been successfully stopped. The second thing is, I personally was looking for our medical records for an insurance company, and the record department here said it would take 30 to 45 days to have them sent to us, which I thought was ridiculous. So I went and spoke to the record people, and I got the records the same day. This is the kind of business that's going on where there are definite problems here.
Mm-hmm. No, so when you're talking about people being able to hack into the system, are you talking about the partner system?
I'm talking about every system. This is what I was reading on the daily JMA.
Uh-huh. Well, so we track unauthorized accesses to the partner system, and as best we can tell, there have not been any unauthorized accesses to the partner system. Is that a real issue? Absolutely. And there are hackers everywhere who are trying to get into to various systems. I guess I would submit that our old approach was not so great. When we were using paper records, a third of the time when the patient would show up, the record was not there. And it's not so easy to deliver good care to someone when you don't have the record. The issue of both privacy and security clearly is ones that need to be addressed in an ongoing way. I think that security is actually better with electronic security, but the risks are also more substantial, because if somebody does get in, they could get at information of a very large number of people, and that I agree with you is a real concern. And I on your medical records point, I agree that's not just not right.
It was just in either yesterday or the day before a paper that if you're applying for insurance, these insurance companies will get a hold of your drug use without your permission, by going to the pharmacy groups.
Right. Well, privacy is largely, in truth, becoming a thing of the past. There's very little that we can keep private anymore. And I think that is a hard thing to accept. I find that hard to accept too. Yeah.
kind of indirectly a safety issue, but one thing that takes away focus from the patient and the practice is trying to do an accurate coding of compliance issues. Are there any IT initiatives to help with that process on an automatic type basis?
Yeah, so that's a good question. So the question is coding and compliance, and we have not focused on that consciously. A lot of the commercial records do a very good job with helping you code in a rational way. I guess my own hope has been that we would move to a more rational approach with respect to coding broadly. We'll see. You know, the current E&M approach is just horrible. I don't know if it's as bad for you as it is for us, but it's horrible. Yeah.
On the topic of efficiency, developing IT systems, there is a certain redundancy within the partner system, where each hospital has its own proprietary program, some of which are better than others. Is there any effort among the hospitals to perhaps pick what providers would suggest are the best programs, focus on those, and then that way that you don't have two hospitals working on two separate programs to do the same thing, you can focus your resources?
Yeah, that's a great question. And we're making an effort to pick the same systems as much as possible going forward. Turns out it's a pretty big change to, for example, take out Meditech and put in a different system. Right. So it does, that is challenging. We are making a very conscious effort to, for example, standardize decision support among the various institutions. And broadly, we are trying to look and say, let's, as much as possible, do the same thing going forward. So your point's well taken. Yeah.
You mentioned that an initiative over the next couple of years is beta and documentation. Is that information coming to labor and delivery?
It will be coming to labor and delivery, yes.
Taking into account the special requirements of labor and delivery, real-time documentation, fetal heart rate?
Absolutely, all of those things. But you'll need to be involved to make sure that it really meets your needs.